Good evening. Welcome, welcome, welcome. So I am here with coder Jen McNamara. Hello, Jen.
Hello, good evening.
I'm also here with Christine Hall.
Hi, John. Thanks for having me. I'm so excited to be here.
And I'm here with Betty Hovey.
Hey y'all, it's usually I'm on Baby Friday, but it's not Baby Friday yet, so happy Tuesday.
All right, so some of you know me. My name is John Pieskowski, and we are collectively trying to start this new weekly panel discussion. And I'm going to be leading most of them. But what we intend to do, this is aimed for new coders and current job seekers in the coding industry. When I say coding industry, it's an overall blanket for anybody with a coding certification or any kind of billing certification. Because all of us have realized that there's a huge growing gap between experienced coders and newly certified coders or coding students when it comes to job opportunities. So what we want to do is we want to reignite that sense of social connection and of coding community that we've had previously, that we've seen since COVID. It's kind of diminished, but we want to bring back that spark.
Well, I am absolutely thrilled that you have created this group. You've brought these people together and to share information about those who are interested in getting in the industry and what the different components in the industry are. And I think even with the example of the three of us here, there's so many different facets of it that different types of fields that you can actually go in. So, for example, in the billing world, you could work in billing either for a private practice, you could work for a payer. They're always looking for people on the billing side, even from the payer's perspective. MSOs, your management service organizations, they're always looking for additional billers to come in and assist in some of the functions within a practice that might be provided through that type of an organization. And I think a lot of times, we don't really talk about all these other roles that could be available.
What do you think, Jen?
Absolutely. No, and a lot of people know me for many years. I've been on the coding side and got into consulting, about 10 years ago, but I've still kept myself boots on the ground in the coding space. To this day, I code for practices because I want to keep my skills up. I can't feel like I can go there out there and advise someone to do something if I'm not actually doing it myself, and I actually enjoy it. So I've always enjoyed coding. I think it's a great field to be in, but I also know there's challenges. I've talked to many over the years who've seen those challenges and even those success stories that made me feel so good. People that years later that said, thank you for helping me get down this path. Now I'm an auditor. Now I'm a manager. And so it feels really good to know that you were instrumental in helping someone stay on that path. So we just want to help. We want to help people find the role for them and stay on that path.
How about you, Betty?
Yeah, in listening just to, echo what the other ladies have said, from my perspective, starting, you get people that start out in one area, they get into coding, or they start in billing, move in to coding, and they kind of don't know what they're looking for. They don't know what they like. That was the one thing I liked about teaching. Years ago, I taught, certification classes. And so going through and taking them through the 10,000s, the 20,000, yes, we would pass through everything. They would get a feel about, oh, this is interesting to me, or I like this one. And so they would, in fact, cardiology, as I know, John, you enjoy as well as I do. I would do that section and I would get people coming in, either say, I never want to see it again, or they really, really liked it. And, but sometimes for people that don't take formal classes and get in the long way, they just don't know. They don't know what they like. They don't know what they don't like. They don't know what to look for. They kind of look around and they just think coding is a very specific thing to them. and maybe don't realize what a plethora of positions there are out there if you have that background that you can go into. And so I think it's wonderful, for you to start. I love the idea when you put it out there to me, that I thought this is just a fabulous idea to do things like that, because I think that's what the newer people need more of, is just to have an idea, like, where can I go? What can I do, with this background now?
Exactly. I mean, that's one of the reasons I decided to do this, is because on Facebook and on LinkedIn, I see there's a lot of discussions about job opportunities, and there's a lot of jobs posted. There's a lot of people that need jobs. And I always see people posting on Facebook, like, where do I want to work? What's the best way to get a job? How can I get experience? Well, these aren't questions that we can answer. Like, these are things that you as a coder or coders out there are going to have to, like, you have to put your own effort out and do that, but we can help guide you into that path. That question about where do I want to work, I see that a lot. There's no
I'd like
way.
to jump in there. I think that you also need to remember that there's so many different positions within an organization. So from a billing perspective, we have our schedulers. They're part of the billing process. They're the ones who make that initial contact with the patient, where we get to find out whether we're billing insurance today, what type of a visit. Is it a sick visit? Is it a follow-up visit? Whether you're the front desk person who is verifying information, are they eligible? And then more so, what are their specific benefits for our practice and how that relates to our practice? And all of that happens way before we even get to billing, but there's a crucial roles within the business office, within the practice itself. So I think, might be that we need to break down what some of those roles. I know that Jennifer and we've got an upcoming presentation, and we're going to talk about the key roles in a practice. And from a professional side, Betty, you can talk a little bit more in the hospital side, but I started off in the hospital side in the business office, and working in the different roles within the business office. So I think that it's important that people understand there are so many different roles in the business of medicine, and it's not just a biller, a coder, an auditor. That is just the main heading, and the subcategories are almost limitless.
Yeah, I mean, think about denial coders. Like, that's another offshoot that you see out there. And one of the jobs people ask me about, if I can't find a cookie cutter coder job, I always say, look for something like that. Get into billing. I was a biller first, and I'm not even tell you how many times I had to address a coding situation while I was fixing a denial, and while I was calling an insurance company and like, oh, this is coded wrong. So then I had to have a conversation with the person who was by title a coder, and I learned a lot. And so you may not think that you're going to get there, but you will if you may have to start from a certain spot and see where you go. Or maybe you're going to walk right into a coding job. You don't know, but you don't want to throw in the towel just because it's taking too long. You need to just be a little bit patient, but know what's out there.
Yeah. And that's one of the main reasons for these new discussions. Kind of give some kind of preview of what each individual job role is. And when I say job role, it's going to be kind of covering each range that you were discussing. When you code for denials, when you code as an auditor, when you do only prior authorizations. These are the roles I want to talk to people individually that are in that role, that hire for that role, and are experts in that role. That way we get this overall perspective of what your routine is going to be on a daily basis. What hiring managers look for in a candidate. And once you get in those foundations, what's the best way to advance? What's the best way to improve your skills to make that better for your employer and to kind of cement yourself as an employee that can negotiate better pay, a higher paying job, better benefits, these kind of nature, things you want to know to better yourself as a coder. So that's some of the reasons I want to have these discussions. And I've made this long list, 122 different roles that I would love to get to. But if I do one a week, I can only hit, 52 a week, give or take a few with the holidays. but I want to talk over the big ones first. So tonight we're going to talk about the difference between what's coding, what's billing, and what's auditing. And with the next few weeks, I'm going to talk about coding only for primary care, how you code or what you see in the office during those type of encounters. And then we're going to go over risk adjustment coding and then cardiology. And then down the line, we're going to go through the list and just kind of talk over things. But that's what I want to do. I want to talk to 3 different people, those who currently work in that field, in that role. They're the ones in the trenches, submitting claims, reviewing documentation. The hiring managers that also do that, but know what's needed to get the job done on a daily basis and what they look for in a candidate. And then experts like yourselves that have been in the field and you know the ins and outs, you know the obstacles, and it's to the point where you can give guidance to kind of further direct these new coders to I don't want to say higher paying jobs, but a higher level of coding knowledge. And that's what the goal is for this.
Well, John, I have to say, if we're talking about what does it really look like, I have a kind of a neat analysis, and I see that the coder is a very scientific job. It is that mindset. You read the documentation and you find the code that matches the procedure or the service that was documented. And it's a science, right? It is what it is. If it's not documented, we look for a category 3 code. We look for an unlisted code, and CPT is really pushing those unlisted codes this year. And we're looking at modifiers. It's a science. If this, then this. On the other hand, you have billing. Well, billing is an art, because what works for one payer doesn't work for another payer. And you've really got to become almost in a rhythm with how those payers are thinking. Medicare processes differently, and United Healthcare processes differently. They've got their policies, which are a little bit different than each one. They've got their own flavor. It's like colors, not the same shade. You've got peach and apricot, and you've got rust orange, 2 different colors, right? So billing is more of an art. And we spend a lot of time really getting to know those. And it's not always going to be the same. Things are going to change. You're not going to like the way those colors look again. And then auditing comes in and basically says, are we doing this right? And not just because I think I'm doing it right, but how do I know we're doing it right? Right. And so when we look at these 3 roles, I think that of those kind of thought process, and maybe when someone's looking for a role, they can kind of mirror what their personality is. Do they like things that are very scientific? This is the way that it is. Do they have more of that artistic mind? Can they flow? Can they move? Can they adapt? Can they change? And then that auditor where you're thinking very almost like litigious, are we doing this right? There's just that black and white. There is no gray. It is the rule follower, right? What's your personality? Where do you fit into that? And that's going to come in really helpful to try to find out what part of this beautiful industry you fit into.
Yeah. And I want to add on to that as well. That's 100% nail on the head right there. But one of the things that I think is also something that we should consider is, do you like routine or do you like change? Like there's a lot of things where when you are in any kind of coding role, you have many hats and things aren't always routine, but there are roles where it's the same in and out. It's the same routine daily. E&M business only, you churn out so many claims per day. And sometimes people like that routine. And again, you'd want to know before you go into role, is this something that's going to keep my interest? If I handle a routine day, am I going to be occupied and keep my mind occupied? Some people like myself, I can't sit and look at all vaccinations every single day. I need change. And that's the kind of personality you need to consider. Are you one that's going to be happy with just coding the same thing every day and seeing the same thing? Because if that's the case, then auditing is possibly the way to go. Because you're so familiar with one specific thing, you can actually educate and audit because of your ongoing experience where you've seen it so often. Whereas with other coding rules, that there's new technology, there's changes, new providers come on. There's always change. So like that's something else you have to consider is it's never the same, but there are rules that are always the same. And that's a big part of it.
Yeah, I would have to second that. And one thing that you just said that kind of hit the nail on the head for me, I'm an extrovert. I'm not going to lie. I'm not going to hide it. I like people. I like to talk. I like to get out there and be in people's business sometimes. But what I learned early on is that not everyone's like that. And there are some coders out there that they don't like confrontation, and they don't like a doctor coming to them and telling them they did something wrong, or having to go to a physician and speak their mind because they have to get the point across to a physician. Now, there's a tactful way to do that. I've seen it done wrong. I've seen the way people talk to doctors, and it's very disrespectful. But I also have seen where you can have an open dialogue, and yes, you may have to speak your mind and show them back up why you're coding things a certain way, but you have to be able to communicate. And so that's another thing is, are you the type of person that's going to speak up when you see something that is incorrect? Or you're going to let it go because you don't like confrontation. And we, all three of us, have worked in compliance. And so we know how important it is to speak up when you know something is being done incorrectly. So that's another thing is think about your personality that way. Can you handle that situation if it comes your way?
Good point.
Yeah.
Good point. It's the art form of, kind of PR relations. There's going to be some work rules where you are going to butt heads, and it happens. One of the things that as a coder I keep having to remind myself is that our providers, their main focus is to treat the patient.
Yeah.
And sometimes they want to keep an eye on our coding, our billing, but really they really need to, let's say, their primary job is to treat. And they take ownership of the coding because they consider it one and the same. So like when we get, when our providers come back and they ask us questions about why did they code this way, it's not out of anger. It's like they truly want to know what kind of treatments they did on this patient isn't reflected in the way we submit the codes. There are some codes where you can code piecemeal, something you can't. Not all coders, not all providers are aware of these rules. They just know that this is what I did, but we didn't bill for it. Why is that? So like understanding the nuances of this and explaining them the right way is sometimes the key to success within that office.
Mm-hmm.
Yeah. I found with auditing, you're also kind of a detective in a way that, a lot of times when I'll do something, and Christine, I know you've seen it, and I'm sure Jen, you have too, you'll see something, you're just like, I know that's not right. It's not right. And then you have to go and think of, okay, now where did I see that, because not everything, as we all know, is written down everywhere. So when the physicians always say, show me, I can't always show them exactly my point. So you have to be able to look for other resources that are like the situation, or where they've made decisions that follow along the path of what's going on. And so you have to be able to liken that and say, well, this is not allowed, or be able to do the research to find the different resources of, okay, in the internet only manual, in chapter 12 and section 4, that you'll start hearing us spout off in 1.c.14.a.2.
Chapter and verse, Betty.
And that's not everybody's thing. Sometimes I spend more time looking stuff up for support for suppurative things than I do actually doing that portion of the work. So understanding those, you're on the OIG website,
Mm-hmm.
you're on looking at the work plan stuff, you're, Komen CMS's site, you have to, be able to know that there are all these little places to go and get information from. And for some people, that's like not their thing. To Jen's, both of y'all were also talking about talking to the physicians and things like that. It's, most commonly with the auditors, they have that educational piece. That's one of the things I really like, is the educational piece. But some people, it's not their thing, especially if they're giving a physician like you didn't do so hot kind of news. I had some people, I was a director in a department, and I had a lady that was one of my auditors that was fabulous. She was a great auditor. She was always dead on. She QA'd real well. And it was every time she was supposed to be meeting with her doctor, something always came up, or, she'd magically be absent, or, we were having these issues. And I was like, what? She did not want to go in front of the physicians and talk to them like one-on-one about their results, especially if she had to say things that weren't, like, you're not doing this right. She was very confrontational, and I said, well, you don't have to be confrontational, but just the thought of sitting with the physicians, she just couldn't handle it. So we moved her into another position where she continued to do what she could do and thrived in it. But that educational and meeting kind of piece is not everybody's bag. So you have to think about all the components, which is why this idea, John, is really great. So people can learn, okay, because auditing people are so like, oh, you just check what everybody does, like you're the homework checker. You can go and see what they're doing. But, there's other pieces to that too. You have to follow through with what you checked and let them know what they did, how to improve, and things like that. And that piece of it, I find some people are just that's not their thing. They don't want to do that part of it.
Well, it's no different than if you're the supervisor, you're the manager, and you have to talk to a staff member that maybe could be performing a little bit better or a little more clearer. And if you do this, then you're going to get the promotion. But sometimes having those conversations with people are not comfortable. So like you said, you got to figure out kind of where your comfort zone is, where that sweet spot is. That position exists. There are so many different positions in the business of medicine, that the position for you exists. It's just learning about the components. As a matter of fact, today, I had someone who is seeking a job reached out to me and said, here's this job, and went on to say that you need to be a coder, CPC, you need to have X amount of experience, you need to be able to do this or this, but it never really gave the true description of the job. And I said, why don't you reach out and say, that this is an amazing position, but I'd like to know more about what the day-to-day looks like. What are your expectations in this role, to see if I'm a match in that way? I'm a match with all of the requirements, but am I a match for what that day-to-day interaction would look like?
Exactly.
Absolutely.
Because if you apply, you go through the interview process and you get hired, and 3 days in, you're like, this isn't for me. This is not what I wanted to walk into. Why put yourself through that? Why put the employer through that? Why would the employer put you through that? There's like a hand-in-hand kind of relationship that if you give enough information prior to that, and if the employer has an honest description of what the role is, and that coder says, yes, I fit that, I will do that, then you're going to have a long-term relationship. But if there's anything where you just need a job and you don't really pay attention to, what the expectations are, it's going to be a very short relationship. And that's one of the things that
That's so true.
I'll tell you a story. So right out of school, I was very motivated to find a job, and I walked into one. I went into an office. I was going door to door, handing out resumes. When people print out resumes and actually went into the office to apply, prior to a lot of internet applications, this was like in the late 2000s. So I walked into this office, and I would stick toward hospitals, and I would go to a hospital area where you'd have all these little offices around that hospital in walking distance, and just every single one of them, just blanket applying. So I walked in one, I had my resume, I didn't make it to the door, and some lady ran out, chased me down, grabbed me by the arm, took me back, and said, "Here's your desk. No applying. Just we need somebody now." That should have been a red flag for me.
I
But
just need a body. I don't.
they just
Yeah,
needed
no
one.
background check, no OIG exclusion list. Like, no.
But
So-
Winifred, didn't you have a similar experience where you went to apply for one job and they
Mhm.
said, no, we think you're better for another role? It does happen.
Yeah, no, I mean, I was not like I was dumbing myself down, but I had just gotten certified. I've been billing most of my career, and I had just gotten my CPC, and I moved to a new area, so I needed to find a job. So I was like, I'm just going to apply for like a biller, like high level biller, because I know I could do that, right? And then it was at a cardiology office actually, and I was a little intimidated with cardiology, but I was like, I've done the billing for them. I know the denials and stuff. So she walked in, she goes, "You're a coder though," because she saw my certification, and she goes, this is like way above your this is like below you." And I'm like, "No, I can do this. I just need a job." Right. But so she ended up knowing a manager across the hall that needed a coder in orthopedics, which is the reason why I am in orthopedics today. It was that interaction. So you never know what's going to lead you down a path. And that's why I love orthopedics today from that experience. But I didn't turn it down. I was willing to do whatever it took to get in the industry.
Yeah. And there are sometimes you have to take that foot in the door job. There was a
Yeah.
comment on here. I'm going to post it by Mr. Germain, David Germain. I'm just going to show it real quick. So they had a great opportunity to start in the field in the field, getting their foot in the door, front desk position. Turn it down because they didn't want to start there. But sometimes you have to start. Like that job that I walked into, that was an AR position, just doing accounts receivable for claims. There's outstanding balances, billing patients. Not one I want to do long term, but it got me experience.
Yeah.
It put me toward getting that A removed from my certification. And then once you get experience and you get a feel for it, you get more confident, that's when you can expand. But sometimes you do have to start small. But
I think of the Rolling Stones, you can't always get what you want. Like that song keeps playing in my head.
I got to come back to that AR position, John.
Yeah.
So I tell my students, that's not a bad job to start off in. First of all, you get boots on the ground experience in what doesn't work, right? So why is something not getting paid timely? And if you really dig in there and you start bringing in that extra, and I won't say extra, but you bring in that AR that's been sitting there stagnant, that hasn't been collected. At the end of your 90 days, when you walk in for your 90-day follow-up and you say, I collected an extra 40,000 in the last quarter, or 20,000 in the last quarter, or 100,000 in the last quarter, how could they not give you a raise? What would be the argument there? You're learning and you're making a difference in the practice. So AR is a great place to start.
I'm telling you what, coders can code right all day long. It does not mean they're getting paid. So when you have people that know how to bring the money in, coder or not, like you're in a valuable role. You are an asset to the organization.
Yeah. It's, one of the key roles of a coder is, to do it right. Make sure the documentation matches what we submit. But one of the key roles of when you're biller, like the impact is financial. You're the lifeblood of that practice. So sometimes you have to take that into account too. And that's like every role in that office is a role because it's necessary. Every person forms this unique function that if there's any lapse in the way they perform, that practice is gonna hurt. So
it's like the human body, right? Like I can't live without my little middle finger and then like my pinky toe. Like I just don't know. Like every single member of the body is valuable. So every single member of the organization is valuable. And we never want to think that any of them are not important because maybe they don't get paid as much or they don't not in the front center of the patient's world. Everyone touches patient data and is integral in the patient's experience.
Yeah, and I think, Christine, when you were talking about the AR thing, it made me think when I was sitting here listening to y'all too, is that people sometimes think of the coding, billing, auditing, so they don't kind of realize that each of those positions has a heavy financial impact on the practice. If a physician, an APP, they could be treating patients all day long, doing surgeries all day long. If they're not being coded right, the money's not going to be right. The coder, once they're coded, when they're coded correctly and they're sent through, if the biller is not on their game and looking at what's coming in, the denials, are they being worked? Are they getting a stack of denials? I swear, y'all, worst I ever saw, I went into an office. It was a CBO for this large multi-specialty set of, I don't even know how many facilities they had, how many clinics. And I walked in, and on the floor, from the floor to about halfway up the wall, there were just stacks of paper that were going around. And they had been without a CBO director for almost like 9 or 10 months at this point. They couldn't get somebody to fill it. And so I was standing there talking to one of the ladies, and she was opening the mail up, looking at the checks, looking at the EOBs. And she would look at one, and she punched a couple things in the computer. She turned around, took that paper, put it on the stack. She turned back around, and I said, I have to ask you, I'm sorry. What did you just do? And she said, well, that was a denial that they got in on. I said, okay. I said, what did you do with it? And she said, I just refiled it and then stuck it in the pile. That was the pile. And I was like, how many times have you redone that? I don't know. So they would just keep refiling it over and over and over. I said, do you think
Isn't
that
the definition of
is just going to
insanity?
give up?
It is.
Yeah. 20th time you got us, I'll pay it. So they definitely have it. And with the auditor, if the auditor is not qualified to be doing what they're doing, they could be saying, yeah, I've seen that too. I'm sure y'all have. Everything looks great. Our auditor said we were 100%. And then I have found where the auditor was auditing their own work. So
I love that one, Betty. I love that story.
And I got a call from them because a payor was like, we beg to differ. And the office was flabbergasted. They said, we don't understand. We always audit great. And I'm like, well, who's your auditor? And they were like, well, the coder's doing it. And I'm like, well, that could be your problem. So if the auditor's not finding those things, everything could look rosy, but it really isn't. So
the coder thought they were doing great. Yeah, I'm doing great. I'm auditing my own work. I'm doing fabulous.
All of those positions that they do on that side, that all has to do with the finances. So any one of those jobs that's not on their toes for what they're doing can really hurt a practice in being able to stay in business to treat patients. So, those roles that people have in those practices, and, as us as independent contractors with their own companies and stuff, that's vital to our clients' well-being financially. And so whatever position that is, I don't like when people say I'm only this, you're not only anything. Any of those positions, has just a vital role in keeping those practices running. So they're all extremely important.
Yeah. I was going to say, recently I had an experience where they had lost a coder, and I was coming in to kind of help them figure out where the money was losing, if it was the coding, if it was where it was. And today I was coding something for them, just getting them caught up. And she asked me why I coded it that way, specific, because we always code it 1/7000, which was frozen. Yes, destruction. Sorry, Betty. I'm like, my brain. It was destruction code, but it was for a pre-malignant lesion, and it was not that. It was 17110, and she just, I'd never seen that code before. And she's the biller. I mean, she doesn't code, but she was just curious while I did that because she'd always seen it come across a certain way. And I explained to her why. She goes, "Oh, well, that makes sense. I looked up the code after you sent it to me, and I realized why." And so it's like, to this biller who'd never had any coding experience, she's figuring this out, like that the coder that had previously was just doing things a certain way. I don't know why, but just little things like that you have a fresh look at it, and your eyes are opened. Like, this is the problem.
So here's a question for Christine that I'm going to kind of pull from what Jen was talking about. Is it kind of more financially beneficial to code correctly, or to just code how it's been submitted, like as it was coded by the provider? Is it like what is the outcome? Like in the end, how does that usually work out?
That's a loaded question,
It
John.
is.
Take it, Christine.
So, first, if we don't code it correctly, we could be losing money, or worse, we could be receiving more money than what we're actually entitled to. So, while I know the providers do their very best to code things appropriately, um, coding is, again, it's a science. It's something that is learned. It's not something that equates exactly as medicine does. Doctors know how to go do a hernia repair. They know how to do arthroscopic surgery. They know what it is that they did, but do they know exactly what that specific code might look like? What the modifier, a pricing or payment modifier, might make the difference on that particular code? Was it performed bilaterally? Were there any extra steps? Were there any lesser steps? Things that billers spend a lot of time learning the different nuances, reading the payer policies. So while I really applaud providers that want to do their own coding, I think it's important that they continue to learn about not just what that code is. And again, I've seen a lot of practices where the providers get very comfortable with a code or a set of codes, and they just keep billing that. Well, codes change. They are revised. They're deleted and replaced. They evolve. We don't see our codes stagnant. And now that we're close to 12,000 CPT codes and almost 80,000 ICD-10 codes, the only thing that we can really count on is change. So I will say, super important that we continue to rely on our coders, who that's what their scope is. That's what they've learned. That's what their craft is, what they have focused on. Thank you, providers. But we still need the coders to come in and verify that those codes are correct. We still need billers to come in and apply the appropriate modifiers, arrange the diagnosis codes, apply the correct diagnosis pointers from a billing perspective. Every denial has a cost associated. So if you have a procedure that, say, has a reimbursement of $100, if we receive a denial, well, now we have just reduced that $100 because we've got to pay out money to touch it again. We've got to pay out money for someone to investigate, to correct it, to resubmit it for adjudication again. So instead of that 100, you've got to take that cost off of what touching that claim a second time looks like. And every time we have to
100%.
touch it, we decrease that reimbursement. So it's important that we do take these roles seriously, from that scheduler, front desk person, educate our providers, make sure we have good cohesive relationships between coders and billers. And don't forget your auditors, who are going to tell you that you're doing it right, or are there opportunities out there, right?
Yeah.
Yeah,
And just Christine to add, oh, sorry, I just wanted to add.
Go ahead, Betty.
Plus the other thing with that, Christine, is not only that, but if you have to touch it a second time, now just think of the time it's taking you to get that money in. The longer you wait to get your money, the less your money is worth. So if you get that denial, then have to spend another 30 days waiting for the appeals process and to get paid correctly, that same $100 that you've now taken the fee of touching it again off of isn't going to be worth it either, because of the length of time you've waited to get it. So it just keeps dwindling down the longer it takes for you to get that payment in the door.
And I wonder if some practices really take that into consideration when you're thinking of how much it costs to bring in a coder or a second biller. How much are you losing by not doing this? And imagine that if you could get everything out correctly the first time and paid correctly the first time, not only would, by having that extra person, but you're going to decrease all that excess waste that you had going out the door.
Yeah, my biggest pet peeve is when I hear, I'm just going to bill it and see what happens. Because, it's like, and a lot of people operate that way. And then they're like, well, I'll just see what the payer says. Well, you know how you can see what the payer is going to say? Read their policy. And I actually have a thing I heard someone just commented, where do you find the payer policies? And that's a hard thing for a lot of people to know. And it's overwhelming for a new person because they don't even know that this is maybe part of their job, or maybe no one told them how to do it. And I had to teach myself how to find things. And I'm in Arkansas, so I happen to have some payers that have some really great ways to find things on their website. I don't usually have a huge issue finding things, but other states and other organizations don't make it user friendly. So I understand, but that's the first thing you should be doing. Grab your major payers. For the first thing is figure out where the modifier policies are, download those, put them in a share drive, make a spreadsheet for all your major payers, find out how a certain payer feels about something, make it a shared sheet, and then everyone can have access to it. If it changes, make a note of it. This is organization. This is communication. Communication is the biggest disconnect between billers, coders, auditors, physicians. Things that don't get done 100% of the time are because of lack of communication.
Yeah.
I
And
couldn't agree with you more.
Yeah, and absolutely. And the information is out there. So there's a ton of information to read if you're willing to do the research. And that's what a lot of your time is spent doing as a coder. It's not just doing the work, but it's also researching to get the correct answer. I spend a lot of time. I'm an auditor during the day, and I do a lot of specialty medicine. And a lot of my time is actually looking up all the LCDs, which is a local coverage determiner for Medicare. To make sure that there's no nuances that I'm doing incorrectly. Just make sure all the I's are dotted and T's are crossed. And then that's what's going to be your early on. That's what's going to take a lot of your time. Once you get more familiar with how the process works and what's common with these things, a lot of payers don't deviate from each other. Medicare sets a lot of rules, and a lot of payers stay close to that. So there's not like one's doing things exactly the opposite. There's this really narrow, I must say, there's really this real narrow pathway where there's any change or any difference from payer to payer. And you can correct me if I'm wrong, but I think overall, it's either AMA or it's Medicare. Those are the two big ones. And there are some that completely don't follow any of the rules, and that's motor vehicle, personal injury. There's a lot of differences in those, but mainly, if you see it happening in one place, there's not going to be a lot of difference. And once you know where to look, Aetna has their own website that has just pages and pages and pages of medical policy per each different procedure. So does United Healthcare. So does Medicare. So does your local Medicare. And that's an important thing to know. Is there's a difference between national Medicare and your local payer. So being able to identify who your payer is going to point you to the right place to locate those individual policies. And again, there's not very many. Like, you're not going to see on everything for every different procedure, but you'll see categories. Like catheterizations have their own policy, or I must say catheterization, heart catheterizations, or orthopedics. There's a lot of rules for leg fractures and arm fractures, rules you have to follow, but they typically kind of generally have a same outcome. There's a code, there's a diagnosis, and there's a medical necessity. Do you meet all of those criteria? If so, likely you're able to submit that code, as long as there's no deviation rules that you also have to put on in addition. But they are out there.
So Alanda, you just like Jennifer had mentioned, you ask, where are they? My go-to is always going to be the CMS MCD website. So if you Google CMS MCD, it's going to take you to the Medicare coverage database. That's going to give you all the national policies for Medicare. It's going to give you the Medicare Administrative Contractor policies, so your MAC in your geographic area. Those policies, when you pull them up, they are two-part. They are the actual coverage determination, and then there's the associated billing and coding article. And the actual coverage determination tells you what is considered, what are the indications that a provider would need to support this procedure. What is the medical necessity that the provider would need to document to support it? Are there limitations to how often that procedure can be performed? And what are the documentation requirements to support that specific code or set of codes to be billed? Now, when I look for payers like Humana, United Healthcare, Cigna, I'm going to use my Google Cigna payer policy for whatever service this happens to be. I might try looking at the CPT code. And those policies are organized in the almost the similar fashion, like John was saying. Those policies are going to tell you what are the indications to perform this? What are the medical necessity? What are the limitations? What are the coding documentation guidelines there? And those are like our Bibles in the billing world. We will follow those and we will use those to make sure that we're representing that procedure or that service according to the policy that's there. And in the case that it's not, that policy is a great education piece to go back to the provider and say, you know, the policy here says that in order to bill this or for it to be considered medically necessary for a payer to pay it, you've got to meet these indications or this needs to be documented. I'm not seeing it. Could you show it to me or walk me through the thought process? My friend Sonal Patel told me that. She said, ask them to walk you through the process. And that's usually where we can find maybe some things that we can improve upon.
Yeah. And in regards to the medical necessity, you know, when you see procedures like, say, in regards to the case for where there was the lesion removal that Jim was talking about, they're not going to use it. They're not going to use a diagnosis code that's going to say like ankle sprain. You know, it's going to be something that's going to be,
Yeah.
and that's one of the things. Like, you know, we would think that should go without saying, but I've seen a lot of office notes where the patient comes in for a lesion removal and the whole past medical history is coded. So, like, these are things that, as a coder,
Yeah.
your diligence is just to make sure that it matches. If the patient comes in for a vaccine, your diagnosis code should not be headache or should not be, leg fracture. Like, these are kind of things that you look for. And sometimes they end up on there just because they were there last time for leg fracture and the code carried over.
Yeah.
But again, due diligence is part of the art, part of the process, and explaining why the patient comes in for had the lab draws, that the reason for the lab draw should be the primary diagnosis. And sometimes that will escape us. You know, it'll escape the provider, you know, and or they'll add things on. Well, the patient came in for a lab draw, but they have diabetes, they have end-stage renal disease, they have hypertension, they have a history of cancer, they have a family history of cancer. So they'll add on all these things, but is that really medically necessary? And that's some of the things that when we audit, that's going to come to light. Do we really need to code all of these diagnoses if we're not treating them?
Yeah, I was auditing today. Sorry, go ahead, Betty. Sorry.
I'm sorry. I was just going to say, as an auditor, that's one of the things where you when you're looking for in this side of the field, like what thing do I like? When you do auditing, you're not just looking at the code, the CPT and ICD-10 relationship and documentation necessarily. I mean, I was just finishing up an audit today. You know, you're looking at are they electronically signed and dated properly? Is it within a reasonable amount of time that it's dated? Is, you know, so you're kind of looking at the whole entire picture. Whereas with, you know, coding, they're looking at a specific thing, maybe billing, you're looking for specific issues. When you audit, you broaden out, you know, the picture that you're looking at. And so that's another thing where if you're looking like, well, what do I think I'm going to like? Kind of, you know, do you like to be super hyper focused on, you know, what you're doing? Do you like looking at the variety like we were talking about? I know a lot of production people that do, they say, oh, I just like that. It's the same. It's nice and even. I could, you know, I oh my gosh, I couldn't, you know, so
Same.
you know, I like, because I look at all different things. I'm looking at different specialties. I'm looking at, but we're also looking at overall, I look at the 1500 forms, you know, so you're looking as an auditor, you're looking for big picture kind of stuff. So if that's kind of where you kind of like your lane, you know, auditing might be yeah, a good thing for you to check out. In addition to, doing with the coding and the billing, but that's kind of how I see with auditing is like differentiating it from coding or billing, is that auditing, depending on the type of audit you're doing, you're like that big picture person. Like I said, you're the homework checker. You're, making sure that everybody did what they were supposed to do and how they did with it.
Yeah, and technology's like just taken off, and we don't know where we're going to be in 5-10 years. So now is the time to really hone your skills and figure out where you want to be. And I'm not saying that you won't have a job tomorrow, but I'm just saying, think about how you can use your skills in the next 5-10 years. AI is always out there. Like, we're thinking about it. It's not going to take over and become like iRobot and just start killing everyone. That's not what it's going to do. It's here to help us, but when we have to control it, any technology has a human behind it, right? I think we get so fearful that we can make up in our minds what it actually is, and we forget to actually investigate what it's actually supposed to do. And AI is a large term. Machine learning is a part of that, which is what in the healthcare industry, what it is actually doing. It's learning what we're doing, right? But it's not going to take over, because a human being like yourself is behind the scenes telling them what to do, making sure those algorithms are in place. And believe it or not, insurance companies are already using it. They've been using algorithms for many years to deny your claims. And so by you understanding the technology, you can be used even in that world. There's a lot of tech companies out there that are seeing the light, that are looking for people just like you who understand the coding world and can help their technology improve. But ultimately, the goal is, of course, to help the patient experience be better. I mean, that's what we're all here for. But we have to make sure we're looking ahead. And I know John's going to have a talk in the future about risk adjustment. It's another great area of healthcare to think about, where you have a niche, but the way the industry is heading, value-based care is important. Getting paid for the treatment of that patient, how sick they are, calculating that risk is really important. So,
well, Jennifer, you made a good point. Just to share a little story. So I have an aunt who fell and fractured a vertebrae, a couple of vertebrae in her back. Could have easily been fixed with a little fusion, right? Make her feel so much better. But because the office submitted the wrong diagnosis code, the coder didn't get the right diagnosis code for her. And so ultimately it started this big loop, and the insurance company denied the surgery, and she went to physical therapy, occupational therapy, MRIs, continued to recommend surgery. Surgery kept getting denied because the diagnosis code that was originally submitted was incorrect. Now imagine how that affects the patient, and it affects the provider as well. We're spending all of this time and money on imaging and therapies and medications when we know what will fix this, but it wasn't coded correctly. So we can't get the authorization on the billing side. It turns into a big mess. And so it's really important that we still have these roles, because again, the insurance company is denying it based on an algorithm that has been created. Yep. That diagnosis code does not equal that surgery. And until that diagnosis gets changed, we can call and say, hey, you're reporting the wrong diagnosis. But if the coder says, no, that's the code, I'm not changing it, or the doctor says, we can't fix the medical record, not that I'm implying that, but again, taking the information from the medical record, if we don't have a coder who selects the correct code from that medical record, we end up in this big spiral there. So every part of coding, billing, and auditing is such a cornerstone of this industry.
Yeah.
And there's always going to be roles. I remember when I began, there was the new EMR. EMR was new, electronic medical record. Everything was paper charts. So people were in a panic. Am I going to lose my job when EMR becomes 100% work? We're still here. So with AI, it's just another way to take off the whole administrative burden from the provider. And that's one of the things that EMR was designed to do, was to take away the administrative burden for the ease of use, ease of access. And that's what the AI is going to function as. Again, there's still going to mean there'll be eyes on every note, but it's going to be more efficient, and we're going to have an easier time doing it. But we're still going to need a coder to submit the claims, to review the claims, to kind of review the documentation. And unfortunately, for a while, we're going to have to be kind of correcting the AI until it learns the right algorithm.
Yep.
So we are coming up on the hour, and I want to do some more in-depth introductions. So we have Jennifer McNamara. So for the new coders that haven't yet met her, Jennifer McNamara runs a company called Healthcare Inspire, and she has been doing this a lot longer than I have. And she is an orthopedic specialist, and I think hematology oncology as well. But she's worked in all these different fields as a coder, mainly medical, in kind of specialty medicine, orthopedics, cardiology, hematology. She's done a lot of those things. So if you're interested in learning more, she has this new kind of patient-based company that's focused on patient care, and she also does a lot of coding work still. She runs I think there's I think you currently run it's one group on Facebook called General Surgery Coding. Isn't that you?
I'm not sure what you're referring to.
There's an online a Facebook group that you.
Facebook. Yeah. Sorry. I was thinking LinkedIn. I'm like, I didn't connect. Yes. So a couple of friends of mine that are general surgery coders, I manage a group for general surgery. We have orthopedic spine. And also I run an ophthalmology group, but yeah, mostly surgical based is where my expertise lies. Most of your surgical specialties. I kind of defer a little bit on cardiology to others like Terry Fletcher and yourself. But I stick more to the orthopedics, general surgery, GI, some of those specialties, ENT.
Okay. Next, we have Christine Hall. So Christine Hall has been here a lot longer than I have, and I've learned a lot from her, from watching her web.
Easy, John, easy.
Listen, I've watched your podcast from almost the minute they came out, and I watch them whenever they are out there. And I do try to catch all of your LinkedIn presentations because they're amazing. But Christine Hall runs a company called Sterling Global Solutions, and here's the website. But she's also she's very into the whole process for billing, as well as she gives a lot of discussion about any updates with any kind of code sets from year to year, from 2023 and 2024. She gives great presentations on what those changes are. So if you're interested, you should actually look at them. I think you did one 2 days ago on the 2024
CPT codes. I did one Saturday and I did one Friday night. I did the Bahamas Friday night, and I did Los Angeles, California on Saturday.
All right, and last but not least, we have Pitty Hovey. So she is the one that's been, I believe, here the longest. So she runs a company called Compliant Healthcare Solutions. Well, because when you do your presentations, you and Christine talk about outdoing each other. I've been here 35 years coding.
Yes, I know.
I love it.
So she's also into auditing. Her major focus is doing consulting for compliance for auditing, and her website is for this company called Compliant Healthcare Solutions, CHCS.consulting. But she's also very prominent. She has her own on LinkedIn presentations like these that Christine does as well. So she also does these with a lot of other coders, and she gives a lot of information about compliance related issues and auditing related issues, and also all kinds of different topics that kind of rise in the meantime, new coding related topics. So if you have a chance to connect with her and look into those. And lastly, me, I am new to this. So I just formed a company called Differential Coding Solutions, and it's mainly going to be these educational platforms where I'm going to be talking about the coding roles and kind of acting as a kind of mentor or leading mentorships, and kind of trying to build that as a thing to do. I try and want to see more of that. I call myself the coding cheerleader because I want to see people in the coding field supporting each other, pushing us to be better. And I think that's something that we need more of. And I want to see more of that from everybody involved. So I want to do weekly presentations where I have experts on. And if you are interested in reaching out and helping out, I want to have presentations in regards to oncology, physical therapy, coding, working behind the front desk, because these roles that we do need. And if you are willing to reach out to me afterwards, I have this long list of kind of coding related roles that I want to do. So the next one we have is going to be next week's going to be primary care. I already have people lined up for that. And if you're interested in learning about what happens during primary care, we'll go over that. The week after is going to be risk adjustment coding, which is also a very hot topic because there's a lot of calls for risk adjustment coders, and there's a lot of calls for primary care coding because there's more primary care offices than normal specialty. And then we'll branch out and go into different topics. So if you are interested, please reach out. We'll connect. But I also want to have the people that I bring in are going to be people that in the near future are going to be able to kind of counsel and to offer these services and this mentorship in these fields. So when new coders see you in presentation, they recognize you as somebody to go to in regards to, I want to do what you do. I want to be where you are eventually. So we can get kind of foster that growth. And that's what the purpose of this is going to be. So I would hope to see you next week and hope to see you in the future. And not every topic is going to be of interest to you, but if you do something that you want to pursue, these are all going to be available on demand once they're completed. But weekly, I chose evenings because it's, I believe, the most it's the most available time for most people after work, when there's no school, there's no other responsibilities, and it's after dinner. But if you can't make them, again, these will be available on demand. And does anybody else have anything they want to add before we cut this feed?
Well, thank you for having me and having all of us. We love to get together, all of us anyway. So, I mean, like, it's a nice little treat to see everyone again. And so we hope that you'll continue watching and learning from all of the individuals to come and their experience.
Oh, I couldn't have said it better, Jennifer. Thank you. Thank you so much, John, for having us. And thank you for everyone who attended tonight.
Yeah, thanks. This is a great idea. I think people that are attending will find it very helpful. And the people that are, watching us here tonight, just find your passion, find what it is. As we were saying, listen, come here and listen. If it doesn't apply to you, come and listen to see if maybe that's something you would like, because you don't know until you hear about it. So this is a good way to get a little bit of a taste of something to see if you want to pursue it further. So it's just a phenomenal idea. And thank you for inviting me.
And again, thank you for helping with this, our first episode, and kind of launching this. And hopefully this will be something that takes off and it's helpful to everybody that does view it, and they can take at least one thing away from whatever we talk about. But again, I want to thank you again. It's been great having you guys on here, and we hope to see you all next week.
Yeah. Thanks.
Bye.
Bye.